Okay. What did I just do there? All right. So, with that being said, I would love to introduce, or I'm going to allow our presenters to introduce themselves. They're going to be presenting managed care today. So, Silka and Ethan, the floor is yours.
Okay, I'll get started and I'm going to turn my camera on really quick so you all have my face. My name is Silke Kramer. I'm a health home enrollment specialist with the Healthcare Authority, and I've been with the program for 7 years. And I am very happy to have the opportunity to present this morning. And Ethan, I'm going to turn it over to you.
All right. Well, good morning, everybody. My name is Ethan Leon. I'm the Managed Care Data and Policy Analyst over here at Home and Community Services. Gosh, I've worked over here now for about going almost 6 years now. And prior to my time over here, I actually worked at Healthcare Authority doing Medicaid eligibility and contracts. Yeah, been in this for probably, gosh, over a decade now. So that's hard for me to say. Yeah. So Silka, just real quickly, did you want me to go ahead and get the slides up, or were you going to present on those?
Um, I I can try and see if I can do it. I've never done it on Zoom before, so
Hey,
uh,
if that's okay, I've got them here if you need me to present. No problem.
go ahead then.
All right. Let me just clean up my screen here. Sorry about that. And then we'll get that up. And then finally, we will share and we will go ahead and go just with that PowerPoint. All right. And hopefully people can see my screen here, specifically the PowerPoint portion of it. If everybody doesn't mind just kind of throwing something in chat. Oh, I'm seeing thumbs up. Excellent. Woo! Look at that. I can still do this.
Yeah,
So
you can.
let's go. Thank you. Yeah, I appreciate the positive support. So as you just heard, you've got both of us here, Silka and I, working for different agencies, but still loving working together. So we'll go ahead and get started on the managed care portion, and then I'll pass it over to Silka to talk a little bit about how this relates closer to health homes, and then also like how to see some of this stuff in systems like Provider One. So, all right, let's get started. So, managed care. If you've been with our state agencies for a while, you may still remember the days where most things were fee for service and then transitioning over to managed care, where the managed care plans took over physical health needs, as you can see in this quadrant right here. And you may even remember some things like the regional support network or even behavioral health organizations. Well, about 2016, we started looking at the model and saying, you know what? It really doesn't make a lot of sense for a managed care organization to take care of the physical health benefits and then have somebody else, be it, a behavioral health organization. And in Washington State, we had 10 different behavioral health organizations and try to coordinate benefits that way because, as we know, you know, people deal with their physical and behavioral health issues at the same time. The body and the mind don't just get to be separated. So the idea behind this is that under the idea of integration or whole person philosophy, you would have one managed care plan that takes care of both the physical and the behavioral together in contracting, where you say, okay, we can build this network so that way somebody can actually get their physical health needs, behavioral health needs, and in a perfect world, these two providers would connect through their insurance company. And that's where you get that blending of services of primary, acute, behavioral health, long-term services and supports, and everything supporting that person. And you'll notice here, done a little bit of talking about that whole idea of fully integrated managed care, taking care of the physical, and behavioral health services only taking care of the behavioral. Why are health home and PACE down here? Well, we look at it as health home being part of that integration model and a really important part where you're talking about not just, okay, we want the person to be healthy physically and behaviorally. We also love to see health home come in as a piece of looking at that person beyond just their physical ailments or their behavioral ailments and say, hey, what can that person look within themselves through their HAP and say like, hey, this is what I want to have as a positive outcome for me. Because I don't know about you all, but when I'm a little bit more positive and I'm feeling better about myself, my health outcomes look a little bit better. My behavioral health needs lessen quite a bit, and even my physical health needs. If I start exercising, my hip starts feeling better, and that's not a joke. 2, 3-year-old boys, and I gotta tell you right now, that hip starts acting up pretty quick. Sorry, refocusing. We also have PACE here, Program for All-Inclusive Care of the Elderly. We also look at this as it is part of this little quadrant, but I'm also going to say if you've dealt with the PACE program in King, Spokane, Snohomish, or Pierce counties, you all will know it doesn't integrate too much with Health Home. In fact, it really doesn't integrate with Health Home because you can't be on PACE and Health Home at the same time. But we like to include it here as one of those integrationals because they take integration to a whole new level in including things like dental, nutritionists, nursing services. I mean, everything is handled by that PACE organization. So we like to include it in here as a model for that whole person philosophy. So let me go ahead and talk a little bit about that managed care model real quick. So if nobody's familiar with how a managed care model works, this is not unique to Washington Apple Health or our Medicaid program. This is any managed care model. So, if you're thinking about like Kaiser Permanente, what used to be Group Health, this is how they do it as well. So, so the way that I like to use this example is that if you have a managed care plan that has 1 million clients and healthcare authority is contracted to pay $1 per client, that is a single premium, that $1 per member, 1 million members per month. So for every month, they get a check for $1 million to build their network of services, be that hospitals, primary care providers, gastroenterologists, neurologists, all of those specialties, all that lab work, x-ray, everything like that. That is how they contract with those providers and build their network so that way their clients can get those services. Now, of course, it's not as simple as $1 for every million. I just don't want to do the math for, looking at all of their fully integrated managed care clients and their BHSO and say, okay, they get this much for this. Just makes it a lot simple. We can kind of do that easy math. Now, you've heard me here say Washington Apple Health, Medicaid. So, Washington Apple Health, that is just Washington's Medicaid program. If you've been to California before, you know that they call it Medi-Cal for their Medicaid program. It's just the way that we've chosen to brand, or I say we. You may hear me say we a little bit in this. It used to be Healthcare Authority, so still hard for me to break away from that. Healthcare Authority uses that Washington Apple Health for our Medicaid branding. Now, there are a few methods of service that are paid for by the Healthcare Authority through that per member per month. Most Medicaid recipients you're going to see will have either fully integrated managed care, where the physical and behavioral are blended together. The other really popular plan that you'll see here is behavioral health services only. And that is a plan that only covers behavioral health services, as it implies. You're probably looking at me right now and you're going, Ethan, you just talked about integration, and you're telling me there's a plan that only covers behavioral health? That doesn't sound like integration to me. Well, there's a reason for that. There's another federal program that covers their physical health, which is Medicare. And when you have Medicare and Medicare covers, Part A covers hospital, Part B covers the medical, physical portion of things, that's where you say, CMS, they get really frustrated when you start double spending dollars. So Medicare basically covers the physical health and Medicaid covers the behavioral health. And that's how we work on getting that integration back into the model. Now, there are a couple other programs that are less common. For example, the fee-for-service program, which actually works outside of managed care. This is one of those situations, and this works a little bit more like our uniform health plans or any PPO plan, where you go into the doctor's office, they see you for your yearly physical or things like that. They say, okay, that's going to be, we'll bill $200 to the insurance. The insurance comes back and says, we'll pay you $120 on our contracted rate. That's how the fee-for-service model works. And that's all handled straight through the healthcare authority. Now, primary care case management, This one is a smaller program still that is specifically for our American Indian or Alaskan Native population. And this one is really interesting because it uses some of the pieces of the fee-for-service model and the managed care model, which you're probably going, oh, how does that work? And if you are, wow, you're an insurance nerd like me, but that's okay. We'll get you through it, everybody. So, primary care case management, it actually works directly with the tribes of Washington State. So, for example, the Puyallup tribe actually gets a per member per month to help build their network in tribal providers. And when one of their tribal members actually goes and sees that approved provider, that provider can also bill fee for service for services. So it's this interesting blend of fee for service and managed care, but it is limited to that group of individuals. And then finally, Apple Health Foster Care. We include this at the end of our home and community services training because you don't typically see 18 plus. However, this is a slightly larger group where they're actually being paid through the foster care system. All right. And Silka, was there something that you wanted to jump in on?
No, go ahead.
Okay, no problem. I am also trying to monitor chat as we're going through this. I don't see any questions yet, but I don't think it's a bad time to pause and say, hey, are there any questions? Thank you, Carrie. I really appreciate that. Carrie is also monitoring the chat. Oh, okay. We're saving questions for after? No problem. I will go ahead and continue on then, and we will talk a little bit more about if managed care enrollment is mandatory. For the most part, yes. There are a few exceptions, and you heard me talk about one of those exceptions just a moment ago. It's the American Indian or Alaskan Native population. They do not have to be enrolled in a managed care plan. However, they do get that opportunity to be part of the fee-for-service network or primary care case management, as we just talked about. Now, the other exceptions, they're a little less common, but we will talk about them right now. Voluntary regions, which will show you a map of the regional service areas of Washington State a little later. The important thing to know is that we don't have any voluntary regions right now, but if we ever did have a region that offered the option of 2 or less managed care organizations, that region would be allowed to, or I should say, that region's residents would be allowed to select fee-for-service as a way of getting their services. And that's because of the fact that as Washington State, we want to make sure that clients have choice. In fact, you'll hear us say client choice is one of the most important things that is offered under Medicaid, which is we're not forcing you to select a particular plan to get your services. We don't want to have those types of monopolies if possible. So voluntary regions try to prevent that by offering fee-for-service, aka healthcare authority, as an alternative choice to people. Now, non-citizen adults that are eligible for emergency room services only, those individuals as well will be part of the fee-for-service network. They can actually not be enrolled into a managed care plan for the most part. And then finally, the last exemption, I include this just because, you know what, sometimes people get a little worried about this, but the official explanation is where the service provider is not contracted, where life, health, functional level is in jeopardy. And you see the wax cited there. What does that mean? Basically, if I've lost my arm and they need to reattach it, there's not going to be a quibbling with the provider over, are you contracted with the proper insurance plan to get that limb reattached? Please, just reattach the limb. We will pay you fee for service after the fact. Don't, jeopardize somebody's life, health, or functional level just to make sure that they're going to get reimbursed. All right. So the managed care enrollment process. Let's say I, Ethan Leon, am an MCO eligible person and I enroll for Washington Apple Health. As of today, November 14th, and I'm found eligible. My coverage is going to backdate to the first of the current month, being November. So if I had any doctor's appointments November 1st through November 13th, I can then go back to those providers and say, hey, I've got Washington Apple Health now. Could you please bill for the services that I incurred in this date range. And most of the time, you would hope they say, yes, we can do that. And they usually will. So it's up to the provider, but they usually like to work with the insurance company more than try to work with a client for reimbursement if they didn't have insurance. And then, of course, for individuals that have had any bills 3 months prior to this month, so let's say November, if I had any bills in October, September, or August, then I could also apply for what's called retroactive medical. If I was found eligible in those 3 months, following the same process, then I could get my appointments covered under the fee-for-service program for those previous 3 months. So, classic clients, so these are your individuals that are Social Security income, age blind or disabled, or long-term care clients. They do not get to pick their plan ahead of time. However, anybody who applies through WashingtonHealthPlanFinder.org, these are your modified adjusted gross income clients, aka MAGI, also known as alternative benefits plan clients, ABP. They actually get the opportunity to select their plan before the Provider One system uses its algorithm to assign them. So they actually get to select that plan ahead of time. Now, let's say for your classic client that they don't like the plan that they have been assigned, or maybe one of the Magi clients goes, oh no, I signed up for the wrong plan. How do they change their plan? So they can go ahead and go to waprovider1.org/client. This is for classic or Magi clients. They are able to go into Provider One, select their plan, and it'll change back to, or excuse me, let me try that again. It'll change in the following month as long as they make that plan change by the 20th. It's the 10 days to the end of the month rule. If they select a plan, say the 21st or I'll say the 22nd of the month, then that plan change won't be active for, like, let's say December. That would then fall into January. And then same thing with wahealthplanfinder.org. For Magi clients, they can go there and change their plan when they would like. However, again, same rules apply. If they don't make that change before the 20th of the month, it won't be active until the month after. And of course, 1-800-562-3022, extension 16131. They can go through a customer service representative or use the IVR, individual voice recognition, to change their plan if they don't have access to a computer or they just don't want to use a computer. And then I also saw a question over here. For clients on spend down periods, which of these plans do they typically fall into? To answer that very succinctly, it's based on the algorithm and what's available in the region. So they don't get the opportunity to select that plan ahead of time. Spend downs are actually kind of tricky because of the fact that they do have to meet a certain spent amount of their resources or income in order to be covered under Medicaid. So if we have a little time after this, let me go back to spend downs and I might be able to talk a little bit more about that. But did that answer your question for the most part? No problem. Glad that I could answer that. And I know, Carrie, I'm sorry. I'm terrible at waiting until the end for questions because it gets me onto a whole other topic sometimes, but I'll try to keep it reined in. So you've heard me talk a little bit about the different types of Apple Health benefits, but just to put it a little bit over the top, that Apple Health plan can cover durable medical equipment. We've talked about laboratory services, hospitals, skilled nursing services, of course, home health, which I know we have to try and split that out, but I know I won't have to do that here for this group because you all know the difference between home health and health home. I don't have to go into it, and trust me, I wish we could change the other program so it's not so confusing. But of course, pharmacy benefits are included under the fully integrated managed care plan. All of these are different types of coverage. But some of the other services available under managed care, you do have things like care management. And it's I hesitate to use the term tiers with this group because I know that means something totally different under health home. So let me say it this way. Level 1 for care management, You have where the managed care plan is just, lightly looking at the client, making sure, okay, yep, we see their health status, they're using their benefits, we're making sure that the providers are communicating. It's really that lowest level of this is basically what everybody gets under their health plan. Now, care coordination, that's kind of level two, where you're looking at, okay, you're getting your own care coordinator assigned. It's that single point of contact who works with the enrollee's family and bridges the many systems of care. If that sounds a little familiar to you, I get it. It does feel a little bit, okay, we're starting to get into that health home territory, but really it's more focusing on, okay, you need a primary care provider. Let's find you a primary care provider. Oh, and you also need this type of specialist. Let's make sure that you're getting a specialist that's contracted in our network. And we're going to make sure with our two contracted, primary care provider and our specialist, they are communicating. And hey, you guys are looking at the medications that are that you two are prescribing for this individual. Let's make sure that things aren't contraindicated. And you start seeing a little bit more. And we're making sure that the client is informed and saying, okay, this is why we're doing these two providers. This is what their plans of care are. Are you understanding what's going on? And trying to help the client understand a little bit more about what's going on with their benefits. Trust me, I think that everybody could use a care coordinator because as much as I love this whole insurance game and everything that we do, it is incredibly complex. I'm the first one to say I've tried to help family members, neighbors, try to coordinate their benefits. It is not easy, especially when you start throwing Medicare into the mix, Medicaid into the mix, and any type of third-party liability. It is incredibly difficult. Then you get this level 3 service, which is transitional care. And that's just to make sure that whenever somebody wants to change settings, we always use the example of hospital to in-home or hospital to a residential facility. Those are types of transitional care where the care coordinator is making sure, and this in this case would be a transitional care coordinator. They want to make sure that that client is going to have a successful transition. So they're trying to make sure, hey, what DME is needed, are modifications needed to the home, what is needed to make sure that that's going to be a successful transition and you don't see that client having to readmit into the hospital. But this can also work for clients who are wanting to change from maybe an in-home to a residential setting or a residential setting to back to in-home. It really can be provided for any of those types of transitions, skilled nursing facilities to in-home. You just sometimes have to get creative and ask the managed care plan, hey, I've got a client who's moving. Can we get some transitional care services for them? So that's how we always think about it. And then also health home we include here, again, just as a different type of coordination of services to make sure that and we want to make sure that it's included because of that person-centered health action planning that comes from within the client with their care coordinator, with you all. So we like to include it here just as like, hey, it doesn't always have to be, okay, it's about, the insurance. It's about the making sure that you do the proper things for your physical health and your behavioral health. It can come from within you as well, and just putting a little bit more power into the client's hands. All right. And we've talked a lot about the different managed care organizations here without actually calling them out. I just like to call them out in this slide here saying, hey, we've got Community Health Plan of Washington, Coordinated Care, Molina Healthcare, United Healthcare, and WellPoint, who used to be AmeriGroup, but if you weren't aware of that change, yes, AmeriGroup has changed to WellPoint, though it has been almost a year, so I'm sure a lot of people are quite familiar with that. Let's see here. And then we also have the managed care cards. For most people, anybody who's enrolled in a managed care plan, they're going to have one of these types of cards. And you'll even see here that we still have AmeriGroup, but they'll have that Washington Apple Health branding, and we'll typically have something like behavioral health or the type of program that they're for. Now, if a client does not say that they were ever given one of these cards and only have this blue screen card, that can actually be an indicator that maybe they were fee-for-service, that they're part of the fee-for-service program or a PCCM. Now, one last thing, or actually two last things now I think about it. We've got the Medicare card here, and this is just to let you know, hey, totally different from the Medicaid cards and everything like that. And you may see things like Part C plans where they combine the hospital Part A, medical Part B, and then typically a Part D prescription plan. We don't go too deep into it on this training, but I'm sure that the wonderful folks here that run your webinars could always tap for a little bit more of that Part C Medicare conversation. We also have our HCA service area map, and this just shows you the plans that are available for managed care under Medicaid. So with that, we are going to move to the health home enrollment. And Nancy, I do see your question. I want to answer that, but I also will open it up now for any other questions, I think, just before we go into that health home enrollment piece. So how can we as care coordinators focus on health when members have worries about food and rental assistance? So that is that's a big question. And the only thing that I can talk about from the perspective of somebody who's worked in the Medicaid system is, and I'm sure you know this, looking at programs like food assistance, looking at programs like, uh, I know over here at Home and Community Services, there are certain types of housing vouchers and housing programs through our housing assistance program. I know that there are other systems under DSHS, and I'll be the first one to say it. I know you all probably know about some of those programs, and I'm sure with the webinars that are here, there could even be a webinar that is probably offered with the ALTSA housing team and DSHS rental assistance programs and things like that that could give more information out there. I will admit I am not the most qualified person to talk about that, but I'm also going to say too, I know it's hard out there. I know that people are struggling, and it is not easy when you're wondering how can I plan the next meal? How can I plan for where I'm going to be staying, living, to think about, well, how do I get healthy? Because that's, in that hierarchy of needs, got to know where the food and the shelter's coming from before you can start looking inward at, okay, now how do I deal with, managing, diabetes or managing any behavioral health needs. Absolutely. And hey, I appreciate that I'm seeing a few things come in regarding for King County, like the Emerald City Resource Guide. Carrie's got in there 211. Yeah, so, Nancy, I hear your frustration, and I wish I could give better information, but um, does that help at all?
Ethan, we had one more question. Foster care get insurance until they're 21, correct? Or is it longer?
So it can go a little bit longer. There is a program, and sorry, I only know it by its ACE's name, which is the D26 program. But it isn't a foster care extension program that goes all the way to age 26. Though I will admit I am not 100% sure on the requirements of that program because it is managed through the foster care team. What I would say is, and Silka, I'm so sorry to throw you under the bus because I know you don't work with the foster care team, though I do know Healthcare Authority has the foster care eligibility team. Could we reach out to them and see what the qualifications for that D26 program is?
Yes, I can do that.
Awesome, thank you. Ooh, oh, this is always fun. Sorry, I don't, this is such a broad question again, but I love it. So what are some of the changes a member can expect when they are switched to Medicare? That depends. What I will say is the most basic answer to this is when you switch from Medicaid to Medicare, you are going from Medicaid, doing most of the physical health services over to Medicare. Now, what does that mean? Well, we need to make sure that and I'm saying we, really the client, but if you're helping the client, this is what they're focusing on. Is their physical health provider, primary care usually, contracted with with Medicare, first and foremost? And that's just talking about the fee for service. They also get the opportunity to apply for, well, they'll apply for hospital part A, hospital part B, but then also have the option to either buy into or select a part C plan, where they can sometimes pay an additional premium to receive a more coverage under, again, a managed care plan, where that hospital, medical, and pharmacy benefit are all rolled into one. Now, Medicaid, if they are still eligible for it, could allow them to enroll into a Part C D-SNP plan. And trust me, I know with Health Home, I've already said the dirty word of dual special needs plan, but it is an option, and they could then go and sign up for a D-SNP plan, which could make their Health Home enrollment a little bit more difficult, we'll say. And then they get that option of having that combined benefit, whether it be through one managed care plan for the Medicare and Medicaid, or if they can choose separate managed care plans for that. So that's my basic thing of how their insurance changes. I'll also ask, was there something else that you were kind of wanting me to describe more in depth, Nancy, on that question? And then Donna, yes, you are muted. So I don't know if there's an option to unmute. I'll look at Anthony and Carrie for that. But if there's an opportunity, if you're looking for a question, please feel free. No problem, Donna. And I'm pausing just a little bit here to see that response to the Medicare question. I'm not seeing a response at the moment. So, Silka, I think I will go ahead and pass the baton on to you. And if we do get a follow-up question there, oh, here it is. Sorry. So does a member have to pay a portion of Medicare, or is it like Medicaid? I'm sorry, I have a member who's just transferring. So, gosh, man, I always hate saying it like this. It depends. So with Medicare, for Part A and Part B, yes, there is a premium that is typically taken out of, well, I shouldn't say it's taken out of, but usually most people will pay for it through their Social Security income benefit. And then if they sign up for a Part C, yep, and Janelle, thank you for throwing that in there. They can't be in health homes. So it really does get complicated because of the fact that with some of the Part C plans, they may not pay an additional premium on top of that Part A and Part B plan. However, they could, if they choose, sign up for a plan that offers potentially more benefits, but with a small premium. Yeah, and unless it's a D-SNP, and there are some limitations, but I hate to say that's why I didn't want to bring up the D-SNP conversation, because it is its own training. So not that I don't want to talk about D-SNPs and how that interacts with Health Home, but I also know that there are other people that could have a whole webinar on that. So,
And that's for sure.
oh yeah, absolutely. Trust me, Vanessa on our team, she'd be real upset if I was presenting D-SNP without her on this one, because she is our Medicare and Medicaid integration program manager, and she is awesome. So, all right. Well, Silka, I think I'll go ahead and pass it off to you and go off camera. Thank you all for giving me the opportunity to, just wax poetically a little bit about managed care.
And good morning again, everybody, and thank you for giving me the opportunity to present this morning. And if you give me the next slide, Anthony, I'm going to start out talking a little bit about the health home history. And the Affordable Care Act of 2010, Section 2703, was created as an optional Medicaid state plan benefit for states to establish health home to coordinated care for people with Medicaid who have chronic conditions. And on October 5th, 2012, the Department of Health and Human Services, or CMS, and our state were the first to partner up with in the Financial Alignment Initiative to test a managed fee-for-service model for providing Medicare and Medicaid enrollees with a more coordinated person-centered care experience. The original demonstration program went into effect on July 1st, 2013, and we celebrated our 10-year anniversary last year. And Health Home fits in great with managed care. And next up, I just want to go over our contracts a little bit and our Health Home coverage area map. And I want to start by saying we have two contracts. We have a managed care contract and a fee-for-service contract. And some of our managed care organizations have a fee-for-service contract in addition to the managed care contract, and that is for clients that age into Medicare, so there can be a continuity of care. And the coverage area map is broken down by the regions that we serve. Health Homes has 7 regions, and if you look at the color-coded map, each region has their own color, and on the right and left-hand side, you can see which health home lead is represented in each region. And in addition, you can see if the lead is a managed care or a fee-for-service lead. And every region has at least one fee-for-service lead. For example, in Region 1, Olympic AAA is the fee-for-service lead. And to assist you in identifying the acronyms for each plan, if you look at the lower middle of the coverage area map, you can see the names, the acronyms and the names spelled up. And on the top of the coverage area, there's also some really informative notes. Especially sometimes the Health Home coverage area map and the Apple Health managed care regions are not exactly identical. And there are some really helpful hints identifying leads that are not managed care plans and managed care plans that are not in all the counties in the coverage area. Can I get the next slide, please? So the Health Home program is a passive enrollment program, and it means potential eligible clients are identified by DSHS RDA. Then they get sent to HCA. HCA confirms the client's eligibility and then processes the enrollment, and the clients are assigned to the Health Home lead. And wanted to just one more time review PRISM. I'm sure you already know about it, but I'll go over it one more time. So PRISM stands for Predictive Risk Intelligence System Modeling. And the PRISM system is managed by DSHS RDA. And RDA stands for Research Data and Analysis. And risk scores are based on the computer models that measure the strength of the relationship of gender, age, diagnosis, and medications. And clients have to have a risk score of 1.5 or greater in order to be initially identified. Oh, what happened to the slides? Ethan, did you lose cover? Did you lose?
Yes, I did. So 1 second, getting them right back.
Okay.
And we're back, I hope.
Okay. And so the clients have to have a risk score of 1.5 or over in order to be initially identified for Health Home services. Again, HCA receives this list. We we confirm that the client continues to qualify for health home and then assign the client to a lead organization. The leads use a smart assignment process to assign their clients. The leads, the client may be assigned into a CCO, or the leads may choose to serve the client themselves. Smart assignment takes advantage of the medical, behavior, and social service specialty of the care coordination organization. And managed care clients become eligible the following month, and dual eligible clients are enrolled 1 month out. Can I get the next slide, please, Ethan? Okay, thank you. I also wanted to point out, and Ethan has already touched on that, HCA and DSHS, we both manage different types of programs, such as foundational community support housing, supportive employment, and there's programs that's both housing and employment. And health home does not affect the client's eligibility for other programs. Can I get the next slide, please, Ethan? I also want to go over the eligibility with everything that we said. Some clients are just not able to enroll in the program, even if they meet all the criteria, and that's due to restrictions in how the health home program is administered. Because the health home program cannot duplicate pre-existing services, clients enrolled in care management programs such as hospice or PACE are not enrolled. And likewise, the PCCM enrollment prohibits participation in the program, although the client can always opt out of his or her PCCM at any time. So we may want to consider this option if the PCCM enrollment is all that is keeping the client from being eligible. And clients with other comparable insurance plan in addition to Medicaid also cannot enroll in the health home program. And let's look at some screens and talk about who is eligible for health homes in the managed care world only. And if I can get the next slide, please. So you would click in provider one on the client screen, and then you would select benefit inquiry. And can I get the next screen, please? And you can either type or copy and paste the client's provider one ID number in here. And you can also, you have an inquiry start date and an inquiry end date. So you can go 6 months back and check eligibility, but it does not go ahead in time. Like you can, it only goes up to the date that you're looking for eligibility. Can I get the next screen, please? So in this example, you see that all the sections are closed, and you can expand every one of them, but you can also see the client in this example doesn't have a health home section, and therefore we know that they do not, that they have not been identified as health home eligible or are not currently eligible. And I just want to note here that when you enter the benefit inquiry screen, the sections sometimes all open up. And can I get the next screen, please? So in this particular screen, this client has health home eligibility. And can I get the next screen, please? And that very same client, here's an example of a client in Apple Health Managed Care with the benefit service packages of ABP, and that's the alternative benefit program. Sometimes you see CNP, which is categorically needed program, and managed care clients can also be CNP or ABP. And can I get the next slide, please? What you can see and what you cannot see. You can basically see if the client has an open health home segment for the current month. You can see if the client's enrolled with a managed care plan or a health home fee for service lead only. And you cannot see if the client who does not currently have an active eligible health home segment is eligible for health home services. Can I get the next slide, please? So if you think or believe a client or person would benefit from the health home program and is an Apple Health managed care client, you can contact the Apple Health managed care plan and request health home services, and the plan will know if the client can be made eligible for the health home program, and otherwise you can check eligibility, and if the client is enrolled with the lead, contact that particular lead. And if they're not currently enrolled, then you can also contact the fee for service lead in the client's region. And with that, I think the health home presentation is pretty much done. But if you want to have more information, you can also contact healthhomes at hca.wa.gov, and I can put that, or Carrie maybe can put that in the chat. And you can also always go to the HCA website or the DSHS Health Home website. And I'm ready to take questions.
You've got a couple questions about health home enrollment, Silka.
Okay.
Okay. Does this look different for DSNP funded clients? And it's in reference to the DSNP expansion in January.
You will still be able to see health home eligibility, and where you saw like the managed care enrollment, you will just see that it is a DSNP plan and the name of the DSNP plan.
Okay. Another question, what are we doing with referrals that are below 1.5?
So if you have a referral that's below 1.5, but you believe that the PRISM score can be raised and that client can be made eligible, we do have a workaround. On the HCA website, we have a clinical eligibility tool. And this tool, there's instructions that come with it. And it's important that you read the instructions. We ask that the clinician fills out the clinical eligibility tool and basically puts all of the, they can program all of the diagnoses and problems that the client has, and they can run this eligibility tool, see if it raises the PRISM score to 1.5, and then send it in to the health home program or the health home email box, and usually in PDF format. And then if there is medical documentation that would support the client's raising the client's PRISM score, if that can be sent along. And we do currently review it on a case-by-case basis.
And Silka, to expand on that, another CC said, I believe that Carla is asking about referrals that we receive from the leads that are below 1.5.
If they are below 1.5, I mean, the client's PRISM score fluctuates. Sometimes the client was already in the health home program, and they have opted out, and now they call the lead and say they want to opt back in. Usually, if it's within a year, then even if the PRISM score is below 1.5, they can re-enroll.
And then you've got a question about the eligibility tool. Does the clinician filling out the eligibility tool need to be an established provider with the client, or can it be an in-house clinician on behalf of the CCO?
Um, that I know of, we have never we have just asked that it gets filled out by a clinician, but we have not said it has to be the client's provider or even in-house clinician can do it. So I would say that both are okay.
Okay. We've got a question, and you might have to go back in the slide. Where was the field in PRISM that showed ABP?
Where was the field in PRISM? Oh, here. It's in the benefit services package. Oh, you want to see where it is in PRISM? It's under demographics. I don't have the PRISM open right now, but it's under demographics.
And then once a member becomes ineligible for the health home service, soon that person becomes Medicaid and Medicare. Who do we contact to get that person back onto the program?
So that person, first of all, what I see sometimes when we get emails about this is that that person hasn't reapplied for Medicare and Medicaid. That should be the first step. They have to be eligible for Medicare and Medicaid. Without that, health home will not happen. So they have to reapply. They can do this through a health plan finder and DSHS, the Community Services Office, and they can also apply with meds. And I believe, and anyway, once they're reapplied, they're eligible. Then the either the health home inbox or the person's health home lead, they can ask that that client be made eligible for health home again.
Okay, feedback. This clinical eligibility tool is very challenging to complete. Is there a way to make it easier?
So the easiest way that I have found is you cannot run it in your browser. You have to download the clinical eligibility tool to your desktop. And then once it's on your desktop, you plug in the information, and there's a button on the top and I'm doing this from memory right now, that says run. And if you click on that button, it does update. It should at least update all of the scores. And if it doesn't work for you, you might want to contact the PRISM administrator.
Okay. And back to the comment about PRISM and ABP. I'm not seeing it under demographics. All that it gives me is the physical and mailing address.
Okay, I don't have PRISM memorized. Somebody will have to bring it up for me because because I don't know. I don't look in there often enough for eligibility. I just know that most of the stuff is under the demographic screen.
Okay, and Pepper, I think Anthony has your email address. So we might have to answer that later. Another comment, even if you see passively enrolled, how can you tell if actively engaged or in outreach? When LTSS case managers or other community members ask how to best guide them to get an answer and coordinate with the assigned lead, CCO, and CC assigned.
So I just want to make sure I understand. You're saying so the client you wanna know if the client is actually engaged with in which lead it is and which CCO is serving the client?
Yeah, this was from Anonymous in the Q&A.
Okay, well, the client, we would know at HCA if the client is engaged because we would get claims that come into the system. But to see if a client is engaged, I would contact the lead.
And Anonymous' answer was yes. Oh, in P1 and ACEs, if a lead or a CCO has access, you can only see if they're passively enrolled.
I'm not sure how to answer that question because to me to I would have to follow up on that.
Yeah, and then it's a continuation. It doesn't tell you if they are engaged or in outreach or sitting on a wait list, not being outreached.
Yeah, because that would to me it would have to go to the lead that the client is enrolled with, and the lead would have to be asked that question.
And then when the long-term care case manager tries to call the MCOs, they won't discuss due to HIPAA. Okay.
Okay, I'm gonna make a note. I'm making a note of this.
Yep, I've got it noted also, Silka.
Okay, thank you.
And then I have another question here. The member will be eligible for both Medicare and Medicaid, but still showing ineligible. Is that in reference to PRISM? Not seeing anything. Provider one, I think. That's what Carly says. So the member will be eligible for both Medicare and Medicaid, but still showing ineligible. And Carly thinks that this comment is in regards to provider one.
So if the client's still showing ineligible in provider one, it doesn't because it's passive enrollment, it doesn't always automatically reconnect to provider one. So usually the lead sends us an email and tells us that the client needs to be re-enrolled in the program. If you see that it's still showing ineligible, then I would contact the lead.
By any chance, do the MCOs or HCA see how beneficial the health home program is by the number of participants there are?
Carrie, you cut out for me. Can you repeat it, please?
Yep. By any chance, do the MCOs or HCA see how beneficial the health home program is by the number of participants there are?
Yes, we do. Yes, we definitely do. Because we do see where the PRISM scores reduce, and there's definitely that's definitely showing that the care coordinators really help the clients out.
Okay, we've got a care coordinator in the chat saying that they had reached out to a lead and the lead agency was not helpful. We've got a comment in here in reference to PRISM. It could be because PRISM is too low or not identified as health home passively eligible. and or be sure to look at end dates on Medicaid, maybe closed for lack of completing financial eligibility review or being denied, for example, over income or resources.
That's possible, yes. And that's a good point.
And then we got another question. Client is out of the country and will not come back, but it still shows as Medicaid eligible. What can we do for this kind of situation?
So I have followed up on emails like this before in the health home inbox. Usually, what I do is I contact the case. I can't close anything up, but I can contact the case manager. What always helps is if you guys have a forwarding address, if you have one, and you can tell us the forwarding address. Then we can close it faster. But I usually report it, and then it's up to the case manager to follow up and make sure that the client's case gets closed.
And Silke, I'm going to bounce off of that one with you because this was something that Anthony and I were talking about the other day. If a care coordinator finds out that their client is going to be out of state or out of the country for 30 days or longer, that should be a best practice and reported to the case manager, so then the case manager can take action. And I know Social Security has rules that if a client is out of state or out of country for 30 days or longer, it needs to be reported along with food and cash. And I love that Heather put in here, if in doubt, I always email our lead to forward it to HCA and check eligibility. And then Pepper's asking, who's the case manager?
So normally the case manager is the person that works at the local CSO office and the client is assigned to. And we would report it to that person.
And the next question, will the member be covered if they have an emergency surgery out of state?
No, we don't generally cover. It has to be pre-authorized. Well, it has to be pre-authorized. It's very tough to get procedures covered out of state.
Is it okay if I answer on the
Yeah.
Medicaid side a little bit? It just like you said, Silka, it can happen. It would have to, like you said, I think of emergency versus elective surgery. In emergency service cases, it really comes down to whether the hospital where they receive those services is willing to contract with Washington Apple Health Fee for Service. And that's where it gets into a little bit of a difficult gray area without looking at it on a case-by-case basis because it's approved on a case-by-case basis based on what the hospital wants. If you're asking what Washington State's policy on it would be, well, it's covered under WAC, but WAC doesn't necessarily apply in other states. So I hope that answered that. But that's why it's difficult and why I feel like I can never give a straight answer to people. It is a curse.
Yeah. Yeah.
And what if they don't have a case manager? And I can answer this one. So if you have a client that's on a Magi medical program, and Ethan could jump in on this too, and say they're on an N05 at the local CSO community service office, you would just call the toll-free number, and that's 1-877-501-2233 to report that change. Okay, and then we have, if we as a care coordinator hear someone is out of state or the country for 30 days or greater, where do we report this? So you could, if they're on an N05 Magi program, which a lot of our clients are, you could report it at the 877-501-2233. If you have a client that's on the long-term care program and they have a case manager or even a DDA case manager or a hospital case manager, that information, the case manager is usually listed in PRISM. And let's see. Feedback on the health home dashboard. If you select the CCO, you can find the contact information. However, this doesn't work for the lead. Can this be added to the dashboard? Silka, you want me to answer it or you want to?
You can go ahead.
Well, on the HCA, the Health Home website, there's actually a list for contacts for the leads, Heather. You might have to find it in resources when you scroll down, but it's there. And then the next question, I would love for one of my members to go to the Mayo Clinic. Can that be covered?
So
Again,
go
yeah,
ahead,
I was gonna
Ethan.
say, again, that speaks to the level of they'd have to go. So you have to have the situation of the Mayo Clinic is offering a procedure that's non-elective, that would be that isn't offered in Washington State. So the short answer to it is probably not. The longer answer is maybe, but there would have to be it would have to go through an entire test of is that service not provided in Washington State? What would the prior authorization process look like with the managed care plan? Would healthcare authority approve the travel? It goes through a lot of different questions. So that is all to say, like I said, if you're asking in a void, probably not. Not to say that it's impossible, but it would have to go through a very rigorous process.
And Ethan, maybe you can answer this one. Can a client be on Magi and be health home eligible? I thought that health home clients had to be CNP level eligible.
So the short answer to that is, as I understand, and I'm going to lean on my health home friends here, as long as they meet that 1.5 eligibility score in PRISM and have active Medicaid coverage, and active being alternative benefits plan or which is the Magi N05 program or a CMP level of care, that qualifies. And that's why that is named alternative benefits plan, is because it is like categorically needy, just alternative because it's based off of income.
I had a lot of N05 clients that were on the program. They had the two chronic conditions, the PRISM score 1.5 or higher, and they were on Medicaid. Will we be able to access a copy of the webinar? I'll answer it for Silka and Anthony and Ethan. Yes, you will. Will there be a time where all leads will receive a monthly eligibility file that can be shared with CCOs?
I do not think so. No. I think that the managed care organizations have to divide it up by county, and then whichever county they are contracted with the CCOs, that's where the clients go to. And I think you would get those eligible clients, but not a list of everyone.
And then we have a comment, probably in reference to you, Ethan. We probably don't see them because we are fee for service, CCO dual eligible. Could this be why? Why we don't see Magi?
Now, just to clarify, is that on the eligibility file or are we talking in provider one? Just could I get a little clarification on that?
We don't seem to have any Magi clients at our fee for service CCO.
I would be surprised by that, and I would appreciate. I think that's one that we can take in follow up because I wouldn't. I'm not even sure why you wouldn't be able to see Magi clients.
Right.
And then we've got Out of state answer. Okay, I'm bouncing in the chat, so bear with me, y'all. Out of state, Mayo answer, maybe, but there has to be expansive proof that the service is absolutely needed and cannot be done in Washington, has taken months, 6+. So that's just one of Carly's comments about the Mayo Clinic. Another question, if a client moved to another state, can we continue health home services for them?
No. No, if a client moves to another state, their entire case and should get transferred to the other state. And then it depends on if that client has that state has health home services or not. But no, in Washington, the case it's another one of those cases that need to be reported, and we need to end the eligibility in Washington, and then it needs to go to it needs to get transferred to the other state.
Hey, comment, transfers to different counties and or states never seem to go smoothly. For us that have been in the field, we totally understand that, and trying to find a contact to make that change is challenging at times. So we hear you, Heather.
So I mean, I would recommend, if you run across the situation that this information would need to go to the lead, and the lead should report it to the health home inbox. That should be the process.
I don't see any more questions or comments at this time, Silka.
Okay.